Thank you. I'm Gary Monteiro. For those of you that don't know me, there's a ton of people here this year. I'm the chief for CV anesthesia, and then Jessica Varisco, who's our patient blood management coordinator. She's not here today, but we work really closely together. So I'm glad you guys had a nice long break. That's what it feels like, because I know you don't get them when you're at work. So just a little business. I don't have any disclosures as far as any companies that pertain to patient blood management, and neither does Jessica. So today we're just going to spend a couple minutes to talk about blood management. You may have heard the term blood conservation, and we're going to talk a little bit about why it matters. What exactly are we talking about? What are some actual things we do? What are some individual things we do? What are some system things we do? And in which hospital settings does blood conservation apply? Giving blood is one of those interesting things that if we need to give it, there's a positive outcome. If we don't need to give it, there can be some negative outcomes. So the real question is, how do you know when your patients need blood? And that's been a question for a very, very long time. Oh, wrong button. There we go. So the why is the blood conservation? One of the things is the idea of managing blood or blood conservation, patient blood management. Blood is a scarce resource. We all see when we get the text messages that there's a blood drive, we're short on platelets, this or that, or we need, if you have this type of blood, please come to the blood bank. So it's a scarce resource, so we need to manage it appropriately so that the patients who need it can get it. There are different society guidelines, the thoracic surgeons, Society of Cardiac Anesthesia. Everyone sort of embraced the idea of how do we appropriately manage for the most part, a scarce resource. Sort of like normal saline is a scarce resource right now. I guess lactated drinkers also. But embracing change, I remember when I was training, we used to talk about red blood cells. Why give one when we can give two? And we'll see that the ideas are changing, that we should maybe just give what's necessary. Jessica loves this slide that, the only people who willingly like change are babies with wet diapers. So STS is this, the Society of Thoracic Surgeons, and they have a whole bunch of guidelines, and this is just the pocket version. Some of the ones that we're going to focus on today are the idea of multidisciplinary blood management teams, meaning that every member of the team that takes care of that patient should be involved in managing the blood resources. Other things, if they're on Plavix, we want to stop that before surgery, of course. There's the concept of trying to get their hemoglobin up before surgery if it's elective surgery and they're anemic, doing anemia workups, EPO plus or minus, or iron plus or minus EPO. Other things we do intraoperatively is we use antifibrinolytics. They list them as lysine analogs, but that's your tranexamic acid that we're using right now, or your Amicar, either or when it's available. We don't see aprotein as much anymore. Blood salvage we used in the OR, which is cell saver. Minimally invasive techniques, for example, doing TVARs instead of doing open thoracos. And then when to use the different blood products. The other thing that's specific to cardiac surgery, which I know we're specific to cardiac service lines here, is we have the additional plus and minus of having to use perfusion when we're on pump. And perfusion, we have a lot of interventions. Microplegias, just giving more concentrated, smaller doses of cardioplegia. We have the ability to use smaller circuits to do different things mechanically, to pull off extra fluids. So in cardiac surgery, we have the benefit and the risk of having the availability of perfusion also, which adds another wrinkle. So why? Choosing Wisely is a campaign where, we basically different specialties pick, a couple main things to focus on with different things. And SABM is the Society for the Advancement of Blood Management. They've actually had their meeting here in Houston in this room before. But some of the things that they pointed out, or we point out also, is that if a patient's having elective surgery and they're not optimized, including from an anemia standpoint, then why rush them to surgery instead of optimizing them? We can do simple things like nutrition, iron supplementation, and hopefully avoid a transfusion in them. Don't do unnecessary lab tests, and we'll see how much blood we actually draw out of patients during their hospital stay, which is a lot. Don't just willy-nilly give plasma. Plasma's always been contraindicated for volume expansion, but we want to use it specifically for factor deficiencies and active bleeding. Avoid transfusion when available, use antifibrinolytic drugs. They've really permeated the non-cardiac world. You see a lot of articles on antifibrinolytics in OB and trauma and in orthopedics. And also be aware and inform the patients of alternative methods that we have for bleeding. For example, and we'll go through some of the cool stuff that we have, topicals. We have different products that don't come from the blood bank for coagulation. So why? How many people are getting blood transfusions? It's a lot. So there's estimates that 1 out of 10 patients that is hospitalized gets a blood transfusion, and the average amount is about 3 units. The cost of administering 1 unit of blood is about $1,200. Obviously, it varies, but it adds up. Transfusion practices vary a ton between institutions and even between clinicians on the same service line in the same hospital. Every single one of you knows that you may have surgeon A do operation A, and that patient's getting transfused. And you may have surgeon B do that same operation, that patient's not getting transfused. So there's a lot of individual variability. And like I said before, while transfusion is beneficial and maybe life-saving in certain situations, there's also a risk to transfusion. Traditionally, people always talked about the risk of infection, and we'll mention that. There's also other concepts of immune suppression. There's an acronym TRIM, transfusion-related immune modulation. There's always the risk of human error, that the wrong bag of blood gets delivered, that the checklists aren't correct, that the wrong bag of blood got delivered to the wrong operating room or to the wrong ICU room. There's TRALI, which is transfusion-related acute lung injury, so an increase in the permeability of the lung tissue. And then my favorite one is TACO, which is transfusion circulatory overload, so basically volume overload from the amount of products given. Everybody knows there are risks associated with transfusion of red blood cells, the most common one being a small febrile reaction. And you can see it as the reactions get more severe, so the incidence sort of drops. And before I said, when I was training, we always learned, why give 1 when you can give 2? And now we're playing with the idea of why give 2 when 1 will do. So it's always a rhyme, Here's a list of possible things that can be transmitted from blood. Obviously in the early 80s it was HIV. Now we have a whole bunch of other ones, kissing disease, Epstein-Barr virus. But the main concerns, we check everything, the blood bank checks everything, is the other things. If you have a patient in heart failure, they're really going to be able to handle a liter of FFP and a liter of PRBCs given rather rapidly. How are their lungs going to take it? So what is patient blood conservation, patient blood management? They're all sort of the same concepts. Jessica likes the real definition here, which is we want to apply the safe and effective medical and surgical techniques to minimize and treat anemia and decrease bleeding associated with surgery or hospital stay. One of the big goals is to manage anemia, and this particularly means manage anemia before surgery. We want to optimize their coagulation status, and oftentimes that just means pausing their elective surgery until their Plavix has had time to wash out. If they go to the cath lab and they get loaded with Plavix, do we need to rush them straight to the OR right away if they need a cab, or are they stable enough to wait? We want the patients to be involved in their treatment. There are special patient populations that every single one of us has taken care of, and based on their preferences, they have different desires for what they're willing to take. You may have a patient who's unwilling to receive red blood cells. You may have a patient who's unwilling to receive platelets. So what alternatives are necessary? How do we discuss it with the patient so that if we get into that situation, we already have a plan? And then employ blood conservation techniques, typically surgically or postoperatively when indicated. So I like to think about patient blood management in cardiac surgery or cardiothoracic or cardiovascular surgery as sort of a continuum, just because I'm anesthesia, from pre-procedure, during the procedure, and then after the procedure. Obviously, pre-procedure, we want to optimize them, treat their anemia, optimize their coagulation, make sure their nutrition's good, make sure they're mobile, all these things that we want to optimize before surgery. During surgery, the big one is minimizing blood loss, good surgical technique, good surgical hemostasis, minimally invasive techniques, avoiding hemodilution, blood salvage. Post-operatively, we want to monitor correct bleeding as we can, discuss what our tolerance of anemia is in that patient for acute post-operative anemia, minimize blood sampling. So what do we do for the patients that we're working up? If we identify that they have anemia, and there are different ways to do this. I don't know if anybody's played with the non-invasive hemoglobin finger probe. We were playing with that for a while. Just, you need to identify that the patient's anemic. After this, we can send them to get worked up. Usually, involves an iron panel, hematology. We do the STS risk assessment. We want to treat their diabetes. We want to optimize them, stop any medication that may increase bleeding, including herbal supplements. We have a preoperative anemia order set through the infusion center that we spent years figuring out with hematology, making sure that their dietary, that they're not malnourished coming into surgery. And ERAS, enhanced recovery after surgery, incorporating all those concepts into cardiac surgery, which is sort of a hot topic right now. So I always like to say, one of the main determinants of red blood cell transfusion is the surgeon. Makes sense, right? Like I said before, you may have a surgeon that does the same operation. They tend to be more likely to transfuse. So I'm going to give you two surgeons, and you figure out which one. It's not anybody that you guys know. This guy or this guy? Okay. One of them we're going to transfuse, and you guys can assign names in your heads all you want. So despite all of our pre-op planning, when it works, the patient goes to anemia clinic, they stop their Plavix. This is what we would like to see at the end of an operation. But we often see blood loss. We see surgical blood loss, whether it's expected with the operation or it isn't. So how do we manage that? Particularly, I'm going to focus on the cardiovascular side. So we have lots of acronyms, of course. ANH is autologous hemodilution. RAP, I'm going to show you, as a technique where we use the patient's own blood to prime the bypass machine. We can hemofiltrate. We do transfusion. We can change the size of the circuits. You can rinse the sponges out and recycle the blood from the surgical sponges. We give the blood back that's sitting in the pump at the end of surgery. ANH is a technique that we used to use a lot. It's not as common now outside of when we have patients that refuse blood, where if their hemoglobin is good before surgery, what we'll do is pull off blood, and we'll actually dilute them. So let's say, just theoretically, let's say their hemoglobin's 14. We may pull off blood and give them crystalloid or albumin and bring them down to a hemoglobin of 10. We'll save that blood for after surgery to retransfuse back into them when we need to get blood back. Sounds a little cuckoo. I mean, it does. It sounds weird. And we have these little rockers, that's all that picture is. And we label the blood. It never leaves the room, so it's not a clerical issue. We don't send it to the blood bank. But what we do is hemodilute the patient and keep them euvolemic. And so if the patient's going to lose a liter of blood during surgery, we'd rather have them lose a liter of blood with that blood having a hemoglobin of 10 than that blood having a hemoglobin of 14. So we save about 4 grams per liter of hemoglobin just by diluting it and saving the blood. Because they're going to, let's say they're going to bleed that much anyway during surgery, we'd rather have them bleed dilute blood. And then we can always transfuse it back, and it has the coagulation factors and platelets in it. So what we do simply, we do it off their central line, is we have citrate bags, just like you would in the blood bank, and we just draw as much blood as we want off the patient, and then we replace the volume with some volume expansion, either albumin or crystalloid. I guess it's albumin now since crystalloid shortage. So that's a technique that we use sometimes. The other one that you may not be familiar with is called wrapping, and it's retrograde autologous prime. So the bypass machine itself is a bunch of tubes and containers, and they're filled with fluid. And that fluid's usually crystalloid with some stuff mixed into it, depending on where you are. But it's basically a crystalloid solution, and it's about 1 liter to 1.5 liters just to fill the tubing and get the air out of it. What that means is when we go on bypass, the patient basically gets a bolus of 1.5 liters of crystalloid, whether they need it or not. In the case where they don't need it, what we can do is bleed. Once the cannulas are in, we can bleed back the cannulas, as you can see here. And what we're doing is pushing the crystalloid basically into a bag out of the circuit and priming the pump with the patient's own blood if they have excessive blood volume. And what that allows us to do is avoid hemodilution from dumping 1.5 liters of prime into them. Autotransfusion, or cell salvage, or cell saver, we use all the time in the OR unless there's a contraindication to it. The contraindications are stuff that you would think of, that it's contaminated, it's infected, there's something mixed in there that we don't want to re-inject back into the patient. And there's 2 ways that we autotransfuse during cardiac surgery. One is we have suction Yonkauer catheters and whatnot, and drop catheters that just suck blood straight back into the pump. The other one is we can suck blood directly into the cell saver and process it. There are different recommendations about what to do, with blood after surgery, or blood from where. We did play around years ago. I'm sure some of you remember with those little baby cell savers that were bedside, that we hooked up to the chest tubes, and the ones that we hooked them up to never bled enough for us to use it, and the ones that bled a lot, we didn't hook up. So, it was a guessing game. But, what do we do with the shed mediastinal blood? Typically we would want to reprocess it before giving it back. So, intraoperative blood salvage, so cell saver intraoperatively. We basically have some anticoagulant that we're dripping through the suction catheter. It can be heparinized solution, it can be citrate, and then we're going to process it and wash it, and then we get red blood cells back. At the end of the bypass run, we dump all the volume from the pump into the cell saver and process it and get every red blood cell that we can back. Another thing that we can do is called modified ultrafiltration, which is very similar to CVVH. Very similar membrane, and we can use it to pull off extra crystalloid and whatnot on the pump. The main difference is that this is just driven by the pressure head of the pump as opposed to an osmotic gradient. So this is just solely driven by pressure, and we can pull off potassium, we can pull off inflammatory cytokines, we can pull off excessive volume. And we can also concentrate the hemoglobin up. Ooh, my favorite topic. So other than stuff from the blood bank, who I love our blood bank here, they're super responsive and easy to work with. But we have other stuff too that I'm sure some of you have been exposed to, or you've been exposed to it a lot. So what do we have for coagulation that doesn't come from the blood bank? Well, we have a couple of things. The thing that you may see a lot of is prothrombin concentrate, and the one we're currently using is Kcentra, and that may change in the future. And what Kcentra has is 4 coagulation factors, 2, 7, 9, 10. And basically the little, if you've seen it mixed up, the little 10, 20 cc's is the equivalent of 500 cc's of, about 500 cc's of FFP. We also have fibrinogen concentrates that you may have seen. And each one of those is 1,000 milligrams, which is the same as a 10-pack of cryo from the blood bank. Factor 7, we used to see a lot of, not as common anymore, still available. DDAVP, we still use, particularly in the uremic patients. And vitamin K, we still see occasionally, particularly for Coumadin reversal, either oral vitamin K if you have time, IV vitamin K if you have less time. And if you have less time than that, we can use the prothrombin concentrates to reverse the warfarin. So years ago, we came up with a Fondren-Brown OR, or it used to be Walter Tower OR transfusion algorithm for patients. And I just want to point out some of the concepts. So we have all of our testing. So the patient's bleeding in the surgical field. We don't know what's going on. So what we want to do is, if the patient's stable, is we want to do lab-based guidance. We don't want to give them every single thing that we can get our hands on because they might only need platelets, say. So we send all the labs, and then we're going to try to follow some sort of transfusion algorithm. You can see if the platelets are low, less than 50, and the patient's bleeding, give platelets. If the fibrinogen's low, fibrinogen. We can do epicenter or FFP on a different side. We may just need to give more protamine. Or the surgeon may have to reopen the chest and re-explore. I think a lot of time there's hesitation to bring the patient back to the OR, right? We're going to treat in the ICU. We're going to watch them. We're going to shake the chest tubes, Then you hold it up, and you see if it's going up or against gravity, this kind of thing. It's getting close to the night. Do we want to take them back? So a lot of these social things play into account too, But, I bet if we did a show of hands, which we don't have to do, how many times have you thought the patient needed to go back to the OR and you were wrong? Versus how many times did you think they didn't need to go back and they had to go back, right? So we have a sense after we have some experience, about whether it's surgical bleeding or whether it's microvascular bleeding, and that's always the jump you want to make, So options for bleeding, non-transfusions options. Obviously, the first one is suture, if they're bleeding like that. The next level that I actually think is super interesting, because I'm sort of a nerd, and I like doing home renovation and stuff. But all the topical stuff, all the glues, all the powders, I just think they're fascinating that they can set under blood. We have all these different products that different surgeons have different preferences for. We have thrombin and gel foam. We have platelet gels. We have Arista powder. We used to have this, the other cellulose powders. We have fibrin sealant patch. We have Surgicel powder. We have laser beams. So there's just so much cool stuff for coagulation now. Obviously, intraoperatively, you want to try a bunch of different stuff, see what works. You want to review your data periodically. I'm sure many of you know Erica Rendon, who sort of runs all the data here for us and keeps everybody on board and is always sharing with us some stuff and some trends and this and that. Attention to detail. If we're dealing with a patient who's not going to accept blood, I always like to see that the A line is put in bloodlessly. The IV isn't leaking on the floor. When you put the central line in, you're not drawing off syringes of blood and squirting them on the floor. That there's an attention to detail, because that's going to carry over through the whole surgery. My job as an anesthesiologist in some of these cases is to make sure that the surgeon can focus and concentrate, that they don't have to worry about what the blood pressure is, that they don't have to worry about this and that I'll take care of that so they can focus on it. And that we have a plan for bleeding is important. And communication. In the cardiac operating room, we talk back and forth with our surgeons, our nurses, perfusion, our circulator. We seem to have a great system for communicating in the operating room. Post-op. Okay, here's some good stuff. So if I drop off a patient to you guys in the ICU that's anemic, they're going to be anemic, right? So if I bring you a not stable, anemic, bleeding patient, they're going to end up getting transfused. Like, that's a no-brainer. So what I want to do is make sure that the patient is as dry as I can get them, that their hemoglobin is as good as possible, that they look as good as I can get them, on the way to the ICU. Post-operatively, we want to minimize blood draws. God, we used to not have the sample lines, the VAMPs. I'm sure people were here before we had those, where we would draw the 10 cc of blood, throw it in the trash, draw your labs, flush it. But the VAMPs are pretty universal now, thank God. We want to minimize chest tube loss, dilution, and then simple things matter as far as coagulation goes. Temperature and acid base matter a lot. Coagulation, part of the factor cascade of coagulation is enzymatic based, which means as the patient is hypothermic, they're less likely to clot, and as their acidotic, they're less likely to clot. So we want to maximize those easy things. Okay. This was actually some data that we collected years ago. So this was just observational, that basically we were drawing labs on every CV ICU patient over at Fondren twice a day minimum. And this was when we were wasting the 10 cc's. So then we just totaled it. And you can see for the 34 beds, it was about 2.5 liters of blood a week getting thrown in the trash. And then you translate that into gallons. And then that many number of red blood cells were just being used for waste before we had the FAMP system per year. So that was pretty interesting because I didn't think it was that much before we looked at it. So post-op transfusion algorithms are going to be very similar. You know, you want to have some sort of lab-guided treatment. Fibrinogen, INR, we can give FFP, we can give cryo, platelets, but then we also have other stuff like the Kcentra. And post-operatively, we're always trying to figure out when do we want to go back to the OR. So I know people have different targets in different places, but this was one of the ones that we came up with here. And obviously, it's a work in progress. So the final thing I want to say is that if we're trying to conserve resources, deal with patients who are bleeding, dealing with patients that are not bleeding, have a system and have a repeatable system, we've got to have the entire team on board. And that's just not the people that see the patient when they get admitted to the hospital. That's their preoperative cardiologist, their internist that's dealing with their chronic medical problems. Are they coming in with an A1C of 10? We want our surgeons to be focused so that they can be meticulous, and dry up as they go layer by layer. We want I want my anesthesiology team, my partners and everybody to be aware of blood loss, have it very high on things that they're thinking about so that little mistakes don't happen. The perfusionists are super involved in the cardiac room. The nurse practitioners, the PAs, everyone that's taking care of them in the clinic before, the clinic after, the ICU, the floor. How many labs are we drawing? The pharmacists. So it really involves a whole giant team of folks, which is, to me, why it's interesting and why we can make a difference. If I decide not to we actually did this. There it is. So what we did is, years ago, we saw that the dark blue line, by the way, is OR cases in Fondren. And then the orange line is red blood cell use. Can anybody guess what happened that dropped our red blood cell usage while we increased the number of cases? We started looking at it. No, out of sight, out of mind. So as long as it was in the forefront, we started thinking about it. And you can see this is blood usage in the OR. One of the interesting things that happened, and I know a lot of people that were in Fondren at that time noticed, was we were transfusing less in the OR, but then a certain percentage of patients were getting transfused more post-operatively. So all we did was push the transfusion down the road. So we started looking at that, and at this point, we sort of come to a happy medium. So we may have, the pendulum came a little far in the OR, it was made up for in the ICU, so we sort of want to balance it on the medium. But you can see our blood usage sort of balanced out over time, even though our cases, 2017, and then COVID stuff doesn't count. But, our cases sort of evened out, and we sort of have reached a level for a happy medium. The other thing that happened is you can see the FFP usage dropped dramatically. That was the introduction of Kcentra to the institution. The cryo use dropped dramatically, and that was the introduction of Rheostat to the institution. And you can see platelets dropped a little, but relatively flat because we don't have a non-blood bank version of platelets yet. So we track this stuff often. There's a blood utilization committee that looks at it. And you can see looking at intraop usage, looking at post-op usage. And you can see just under January, right there, you see intraop blood drop down, sort of like a nosedive. And then what did post-operative usage do? Shot up. So you can see the trend remains the same. So that's some stuff that we're looking at. How do we sort of get rid of that variability? Because you always see that. If one goes down, the other goes up. So do we save money doing that? Like, does it matter other than patient outcomes? You know, does the money matter? The money matters a lot. So you can see the amount of transfusions that we're doing. So we compared 2012 to 2013, and we just made it $900, which was on the low end of how much a unit of blood costs. And just in cardiac surgery, cutting from 954 units to that many units, conservatively, we saved $1.1 million between those 2 years. So there's a cost savings. And the good thing is, if I don't transfuse a unit of blood, I get that money directly. It comes to my... I'm just kidding. I'm not sure where it goes. It goes somewhere. So that doesn't mean we shouldn't do it, you know. But this is just another visual of how to think about patient blood management. There's all these different schematics that people, you know, like, where we have these different modalities and we overlap them with the goal of improving patient outcomes, getting them out of the hospital faster, having less of the negatives, more of the positives, you know, optimizing coagulation we talked about, being interdisciplinary and talking about it, having plans for patients, managing anemia before surgery, also managing anemia after, but then also involving the patient in the decision-making process. So when it comes to blood conservation, it's like sailing. You know, Jessica and I talk about this all the time. And if you guys don't know Jessica, definitely reach out to her if you have an interest in this, because she's an awesome resource. So we have a direction we're going. We want to reduce transfusions. We want to have better patient outcomes. We want to have better cost efficiency, yada, yada. But it's like sailing. And everyone that sails knows you don't go in a straight line. You sort of head in that direction, but you're, you know, tacking back and forth and whatnot. So that's why we always want to be reevaluating what we're doing, even though we have a direction in mind. And that's really fun. If anybody wants to get involved, there's a lot of talks about blood conservation during any given month. You know, we have transfusion committees, we have blood conservation. There's definitely getting involved with the non-blood or the blood refusing patients. So that's all available to everybody. Some references and where some of the guidelines are from. I think that's about early lunch now. So, and if anybody has any questions, I'm happy to answer. Oh. Hey.
The cost of the medicines that are those expensive compared to the unit of blood?
It's an interesting question. Well, when we originally thought about shifting over, the argument was, well, these medications cost more than FFP. We did a cost analysis, including the amount of operating room time we spent, the amount of time thawing FFP if you don't have it already arranged, and getting it out of the Pyxis is faster. If you think about the cost per minute of operating room time and the fact that the fastest available machine to thaw FFP takes about half an hour, right? So if I call for FFP, you know, clerical checks, safety checks, thaw the thing, you know, hey, can somebody pick it up, get it? So about an hour of operating room time just waiting for your FFP to get there exceeds the cost of the medication in and of itself. So, and then you think, if I give this FFP, I'm going to hemodilute the patient so that now they're a hemoglobin of 8, which is borderline and going to piss off my ICU team if I show up like this. And then I give them a liter of FFP, now they're hemoglobin 7.2 when I show up, and then now they just bought an RBC. So, but we did a full cost analysis on it, because otherwise the powers that be wouldn't have let us shift over. And same with Rheostat. So, cool. Well, I'm glad I answered all your questions, because I don't see anybody else having any questions. So, thank you.